overwhelming response because the way you had interacted with me, and you wanted me to show a few more things. So I just started with a recap. I will share my slide and just let me know if my slides are visible.
Yeah, they are visible.
Yes. So today, what I'm going to do is take you towards to what is a closed spinal dysraphism, and we will be dealing with diastometamalia, caudal regression, the complete sacral agenesis, partial sacral agenesis, rib anomalies, and so on. We will start with a recap of the first session, that is how to evaluate the normal spine. The four steps in evaluating the fetal spine in sagittal section would be assessment of skin overlying the spine, evaluation of the spinal curvature, evaluation of the vertebral bodies and intervertebral disc space, and assessment of the conus medullaris. How do we look at the conus? Is through proper mid-sagittal section. So here what we see is the skin line, the ossification centers, the posterior ossification centers, and these are the anterior ossification centers. When you pass the beam through the posterior ossification centers, then you will hit at the conus. And this is how we evaluate the conus in the sagittal section. Now, the spine in axial section, what are the 4 points to look at? Intact skin and soft tissue overlying the spine, convergence of the posterior ossification centers, evaluation of the vertebral body, assessment of the spinal cord, and it's the cord position in relation to the vertebral body. These are the 4 points what we would evaluate in the axial section. And coming to evaluation of the spine in coronal section. So the first step is assessment of the vertebral bodies, a single row of echogenic foci. If you cut at the anterior ossification center, then you will be seeing a single row. Evaluation of the posterior ossification centers, where you see the 2 parallel rows of echogenic foci. And when you do the coronal section, you will be able to evaluate the ribs as I have shown here, and you will also be able to see the sacral tip in relation to the iliac bones. So these are the 4 points what we need to see when we are doing the coronal section. Finishing the sagittal, axial and coronal, and how do we do a multiplanar imaging? Whenever we do a volume acquisition of the spine, as I've shown here, the placement of the volume box is very, very important because I want to cover the thoracic spine. Next, if I want to do the lumbosacral spine and I want to look at the conus must initially be visualized at the time of volume acquisition. So you see now, I'm placing the volume box, seeing the conus, and then acquiring the lumbosacral position. So the entire spine cannot be acquired in a single volume, and hence we take 2 volumes, one, the cervicothoracic spine, and the next is the lumbosacral spine. Once we have acquired a volume like this, and then you can manipulate with this volume. And as I told in the first session, you can use the omniview line to show the anterior ossification centers, which are the vertebral bodies. You can use the omniview line draw it on posterior ossification centers, and you can see the 2 echogenic parallel foci seen clearly. And if you add VCI, you will get the entire spine in the multiplanar image. So this is about volume acquisition of the fetal spine. Remember, when you acquire the volume, please see to it that you have included the area of interest in the volume. See, for example, in this second volume, what I am acquiring, in this, there I cannot see the ribs entirely. So this is not what I want to do. So the placement of the volume box is very important when we do the spine. So now we go to the talk per se. This is what we did on the first session. For the second session on closed spinal dysraphism, this is characterized by failure of fusion of the vertebral bodies due to abnormal fusion of the posterior vertebral arches. And there is unexposed neural tissue. The point is, you have unexposed neural tissue and the skin overlying the defect is intact. So that is closed spinal dysraphism, and hence in closed spinal dysraphism, the intracranial signs will be absent. You will have a normal posterior fossa. So the same thing holds good. Look at the skin overlying the spine. And when you do the intracranium, your posterior fossa would be absolutely normal. You would be able to see the cisterna magna here. In contrast to the lemon sign and the banana sign, what you see in an open neural tube defect, the the most important point here is to evaluate the vertebral bodies and the intervertebral disc space, because that's very, very important when we are dealing with identification of vertebral anomalies of the vertebral bodies and the evaluation of the codes. The lumbosacral curvature is also important because the lumbosacral curvature will give you a clue for sacral agenesis. Now, please don't go for a cup of coffee. I have only one slide on embryology, and that too applied embryology, what we need to know. So, the process of gastrulation is nothing but the conversion of a bilaminar to a trilaminar disc, and you see the mesoderm incorporated here. When you get to the mesoderm incorporated here, and then you see the notochord, this notochord actually induces the neural groove, and then you have the folds of the neural groove. And as this they merge with each other and they get detached, and then this is the neural tube, and you have the closure of the neural tube here, and this is the notochord, and the ectoderm completely seals the the skin covering here. So this is the notochord formation. Okay, and then this the process of secondary neurulation is what when you have a tail bud here, and then the tail bud cavitates to form the secondary neural tube here, and there is a merger. This is there is a merger when this is the primary neurulation and this is the secondary neurulation. When these two merge with each other, you have a continuous spinal canal. Now, why should we know about this embryology is just to know that what are the probable abnormalities what you can have. So when this neuroectoderm fails to detach completely, then you can have what is a sinus tract, a dermal sinus tract is possible. And what are the disorders of notochord integration and what are the disorders of notochord formation? So that is how we will classify closed spinal dysraphism. So if you take complex dysraphic states, disorders of midline notochord integration, in there you will have the neurenteric cyst and diastomatomyelia. And in disorders of notochord formation, you will have caudal agenesis and segmental spinal dysgenesis. And these are the things what you will have under simple dystrophic states, where you can have a whether simple tethered cord syndrome, a tight phylum terminal, filar lipoma, etc., and so on. Now we'll come to the prenatal because all this spectrum cannot be identified prenatally. We will just stick on to what can be identified prenatally and what is the relevance of identifying closed spinal dystrophism in utero. So the first thing is the congenital dermal sinus. So what you see here is a subtle subcutaneous swelling here, and this once again we reiterated the importance of amniotic fluid surrounding the spine. That's very important. Only then you can identify these subtle swellings here. And when you do the transverse section, you identify that there is a sinus tract extending inside into the neural canal, and this is how you identify the congenital dermal sinus. You could use volume HD live rendering to show the congenital dermal sinus, and this is the sinus tract extending into the neural canal, and these are the postnatal images. Now coming to tethered cord syndrome. So a tethered spinal cord can be diagnosed if the conus medullaris lies inferior to L3 at the anomaly scan. See, if you have an open neural tube defect like this, almost always you have a tethered cord. So the conus medullaris typically extends far below L3 and often to the exact site of the defect in open spina bifida. This will also happen in closed spina bifida. And if you have a lesion, a subcutaneous mass, then you have to track whether this conus, the cord, is actually extending to the site of the lesion. And that exercise we will do in the next forthcoming slides. So this is open spina bifida, and it is very easy to see the cord exactly getting attached to the site of the lesion. Now, once again, a recap of what we have done in the first sitting is how to look at the conus. You see that the conus is a dark triangular structures surrounded by echogenic lines at the caudal end of the spinal cord. And this is how the conus would look like. And you also have a way to objectively define where the conus is, and that is the measurement of the conus distance. It is the distance between the conus medullaris to the last ossification center of the spine. So you have to measure this distance, which is the conus distance. And you will see that in a tethered cord syndrome, the conus distance will always be lesser than the fifth centile. The best fit formula is the femur length minus 8 millimeters. And this is how you look at the conus and do measure the conus distance. Now we'll come to how to evaluate the conus in a multiplanar image and do the level and ascertain the level. This is how I showed you how to do a volume acquisition at the level of the conus, and then place the dot and then correlate with multiplanar imaging, identify the level where the conus ends. Now, whenever you suspect there is a low-lying conus, similarly acquire a volume, place the reference dot at the end of the conus, and then add VCI. When you add VCI, you will be able to see the ribs here, and from the last rib, if you start counting, it will be L1, L2, L3, L4. You know the reference dot is at this level, and you identify that this is going to be a low-lying conus. You also understand that when you have acquired the volume, you also see that there are areas of unossified vertebra here. So this is going to be definitively an abnormal conus with a partial sacral agenesis. We will come to the 2D images and then I'll take you to multiplanar imaging. So when I said in the axial view, you have to evaluate for the cord structure in relation to the vertebral body, and you see the cord closely hugging the vertebral body and the cerebrospinal fluid close to the lamina. So you see the cerebrospinal fluid close to the lamina. This is under normal conditions. Whenever you have a close to spinal dystrophism, you see that the pedicles actually are a divergent, and the cord actually is not hugging the vertebral body as in a normal case. The cord is lifted up and attached to the skin, and you see that there is a subcutaneously, though there is no swelling here, you understand that this is not the normal feature here, and you see an isoechoic lesion here where the cord is getting attached to the skin here. So that is how you identify a closed spinal dystrophism. So what are the conditions where you can have a reduced conus distance? So whenever there is a closed spinal dystrophism, or you have partial sacral agenesis, or you have a lumbosacral diastometamylia, there can be a tethered cord. So look at this. This is the conus where it is ending. And you see the conus distance is only 9 millimeters. And you can see that if you consider the last sacral ossified sacral vertebra as S4, now it is difficult. Now you do not know what is S4 because you have missing sacral vertebral bodies here. So ideally in these circumstances, the conus distance will help you to let you know that this is way beyond, very, very low, way beyond the fifth centile for this period of gestation. Now we'll come to the closed spinal dystrophism with a subcutaneous mass. So what you see here is, when you look at the skin surface, you see that there is a small subcutaneous swelling here, and then if you track down the conus, then the conus actually here is ending at the L5S1 level. So the first thing what caught your attention in the sagittal section is that you have a small subcutaneous swelling, and obviously you have the skin covering here, and you are also looking at the low-lying conus. In these conditions, the intracranium would be absolutely normal. When you take the axial section in these conditions, then you will see this is once again a normal for comparison. This is what I just now showed. There will be a divergence of the spinal pedicles. They will not converge with each other, and you see the cord lifted up. And as you see here, can you see the sacral? This is the conus and how it is going down. And as I'm taking you towards the axial sections, you can nicely see the divergence of the the pedicles. So the U sign, what you see in an open spina bifida, is also seen here, but You have intact skin and soft tissue over the level of which the spinal pedicles are divergent. This is in contrast to what you see in open spinal dysraphism. Now, when you do a multiplanar imaging, yes, with the position of the reference dot, you can identify which at which level the conus ends, and this is how it will be a very small subcutaneous swelling, but you understand that there is an underlying spinal dysraphism and a low-lying conus. Now, look at this. When you just attempt to look at the conus, you understand in this scenario that you do not see the triangular structure at all. There is no, you cannot see the conus and the phylum terminal. Rather, you see the cord going and getting attached at this level, and you see this tissue here, this subcutaneous tissue here, where you can see the cord getting attached. And in fact, in this case, you do not even have a subcutaneous swelling. So this is an isolated tethered cord. And if you measure the conus distance, once again, it is only 1.1 centimeters. And you see that this cord actually goes right up to the skin surface. And how do we confirm that in the transverse section is the divergence of the posterior elements of the spine and the lifting of the cord towards the skin surface, and the cerebrospinal fluid seen not at the lamina but between the vertebral body and the cord. I once again brought these images because at the end of the first session, there were many people who wanted me to once again demonstrate the cord lifting off from the vertebral body, and this is how the whole thing would present like. So how would you ever identify this? Is just if you have the habit of looking at the conus, when you try to track the conus, you won't be able to see the conus. Instead, the conus will track down to the skin surface, and this is how you will identify an isolated tethered cord syndrome. Now, look at this case scenario. At the NT scan, this is 55 millimeters, very high BMI, poor penetration of sound waves, and the spine looks absolutely okay. When you do a scan at the mid-trimester, you see a small subcutaneous lesion, once again similar to what I showed there. And the intracranial signs will be normal. But just look at this. The skin always carries a layer of a hypoechoic subcutaneous fat along with it. So, whenever we have a query, whether this is going to be an open or a closed, the first thing is to look at the intracranium. The second thing is if you use a little higher frequency probe, then you can clearly identify not only the bright echogenic skin line, but also this layer of the subcutaneous fat going along with that skin line. And this tells you that this is not an open neural tube defect. So now you know that there is a swelling like this. And when you track the cord, so whenever you have a swelling like this, the first thing once you have ruled out an open neural tube defect, the next thing what I will try and look is, let me see where the conus ends. So if I can see the conus, or if I can get to the conus, now I'm just trying to track the hypoechoic conus and the phylum terminal. But what you see here is the cord actually ascends up to exactly at the level of the subcutaneous swelling. So here also, the previous case, you see that you cannot differentiate the cord, the conus and the phylum terminal. The cord actually gets tethered to the skin here, and here the cord actually goes up to the subcutaneous swelling, and what actually is here in this region. So when you use multiplanar imaging, this is the conus, and this is the phylum terminal, conus in the coronal section in the multiplanar imaging. And look at this. This is what you're seeing here. This is the fatty tissue, which is actually, this is the cord. And you see the skin, the fatty tissue and the cord fat interface, which is a lipomyeloschisis. So much of information you can get on 2D and 3D imaging, and you can see the divergent pedicles of the spine. So this is how to evaluate the conus in the presence of a subcutaneous swelling. Once we have finished this tethered cord syndrome and isolated tethered cord syndrome and what is the lipomyeloschisis type, now we'll go to the complex dystrophic states, which is a diastomatomyelia and a neuroenteric cyst. So, what is a diastomatomyelia? So, it's otherwise called as a split cord malformation, where there is a complete or an incomplete division of the spinal cord into two hemicords with a single or a separate dural sac and an arachnoid space. There is always a sagittal septum. It may be osseous, cartilaginous, or fibrous. If it is osseous, then we can identify by ultrasound. So look at this. This is the bony spur, and you see the divergence of the pedicles of the fetal spine. Now, the key sonographic finding in diastomatomyelia is the coronal section. In the coronal section only we will have a clue for diastomatomyelia, and the first sign what you see here is the presence of an echogenic focus traversing the spinal canal, and you have widening of the posterior ossification centers of the vertebra, and you will have intact skin and soft tissue overlying the affected spinal segment. And you can see the bony spur in the sagittal section. In the coronal section it is clearly evident, and the widening of the spinal pedicles is more evident in the coronal section. So look at this case scenario. So this is the sagittal section of the fetal spine, and it is easy. This is the cervicothoracic spine, and this is the lumbosacral spine, and it is easy to pass off that everything is normal. When you take a closer look, you understand that there is a bony spur here, and look at the level of the conus. So if you look at the level of the conus, and I actually made a point to measure the conus distance in each of the slides. But even if you do not measure, you will truly identify that this is a low-lying conus, because simply even counting back from the vertebra, S4, S3, S2, S1, L5 level. So you see the conus at L5 level. So that is how you can identify. See, I know I have a bony spur, but even before I went to the coronal view to confirm whether this is a diastomatomyelia, I just checked on the position of the conus, because this will give me a clue whether there is an as an associated low-lying conus with a diastomatomyelia. So now look at the coronal sections. When I do the coronal, the diagnosis is bang, because you know there is a bony spur, there is a widening of the posterior elements, and that is why the coronal sweep of the spine should not be missed while you do your routine anomaly scan. So you see this is the widening of the pedicles, and you see the central bony spur here. And when you do the transverse section, you can see the divergence of the spinal pedicles, and in fact, you see the bony spur here going inside the neural canal. And if you see closely, if you just closely appreciate here, you can see the two split hemicords. See, these are the two split hemicords. And this is the bony spur traversing the cord and splitting it into two, and you can appreciate the two hemicords. So this is one level above the bony spur, where you see the cord, and the central dot is the central canal, the single echogenic dot. And at the level of the bony spur, you see the two hemicords. So in diastomatomyelia, if you want to evaluate the hemicords, the ideal section is the transverse section. If you want to evaluate the divergence of the pedicles, then that is the coronal section, and the bony spur is evident in the coronal and in the sag views. And this is a 3D rendition where you can see the bony spur here, and you see the sag section of the spine. This is the coronal section at a slightly superior level, where you can see the bony spur in the midline, and this is the widening of the pedicles of the spine. So that is a diastomatomyelia. Now, but again, this is once again to reiterate the fact, whenever you see a bony spur and you know it's a diastomatomyelia, and especially if it is in the lumbosacral region, the chances of a tethered cord is very, very high. And you see that if you try and look at the conus, here it is absolutely difficult to find the conus, and you see the cord actually tracking down to the level of the bony spur, and you see a small appendage, a small skin. It's very subtle, but it is there. There is a subtle protrusion here, and you see the cord actually, you don't see cord structures, you just see the echogenic elements of the cord all going lower down. And can you see the divergent spinal pedicles? So the importance of looking at the sag, axial and coronal, and then you get the entire picture. Leaving off diastematomylia, will come to a neuroenteric cyst. So it's a localized form of a dorsal enteric fistula, and the cyst is lined with mucin secreting epithelium similar to the GIT and typically located in the cervicothoracic region. And this is how you see the cyst here. And when the cyst, whenever you see a cyst in the posterior mediastinum, you need to evaluate the vertebral bodies. And when you have an abnormality in the vertebral body, then this is going to be a neuroenteric cyst. In this particular case, you also have a diastematomylia. You can see the two hemichords here. So the spinal abnormalities tends to occur in a bunch. So you have to evaluate everything together. And this is a late first trimester diagnosis of a neuroenteric cyst. You see, once again, you have a thick-walled cystic lesion with septation in the posterior mediastinum, and you see the vertebral abnormality here. You see the missing vertebra, the clumped vertebrae together, and once again, this is a neuroenteric cyst. Now coming to, we are finished with the diastematomylia, neuroenteric cyst, and now we are coming to the notochord formation, which is caudal agenesis. The most severe form of caudal agenesis is the cyanomelia. So what you see here is an abrupt S-shaped fetal spine. And if you see the lower limbs, you have only a single femur and a tibia. And you see that there is the lying down adrenal gland on both sides, bilateral renal agenesis. And this is the single femur, rudimentary tibia. And you see that the spine abruptly ends here, that if you take this as T12, last rib, L1, L2, L3, L4. Abrupt ending of the spine here, fused iliac bones and the single femur. So this is the most severe end of the caudal regression spectrum. When we come to the other ones, on a routine anomaly scan, look at this case. So you see the posterior fossa being absolutely normal, but when you just try and look at the spine, you see that there is an abrupt ending of the fetal spine. And then when you look at the conus in this case, the conus is ending very, very high, and it is no longer a triangular structure. It is a broadened structure. And now you must remember what embryology says when you were speaking about secondary neurulation. So whenever there is a merger, so now what happens, there are two types in the caudal regression. When the tail bud is not there at all, now only the primary neurulation is there. You don't have the complete absence of that tail bud. What will happen? The conus ends at the level of the primary neurulation where it ends. So the conus will be very high up, and you see the blunt ending spine here. And whenever you have a spinal cord like this, immediately your next attempt will be, how are the lower limbs? Maybe it's not a cyanomelia, but you look at that. Abnormal posturing of the lower limbs with hypoplastic extended lower extremities, and you see the abrupt ending of the spine here, and you can count this spine also from the ribs, and you can see that the entire sacrum is not here. And when you have a immediately when you go and do the transverse section to see the iliac bones pose each other in the midline, and this is called as the shield sign, a feature of complete sacral agenesis. Look at this. When you do the rendition, you can easily see the sacral bones kissing each other, and that the spine is ended way before the iliac bones. And to get a complete picture, this is a normal spine, this is the iliac bone, and you can see the sacrum lower down. So what's happening here? This is the T12 vertebra, L1, L2, L3 itself, it has stopped, and you see the opposing iliac bones, and this is once again complete sacral agenesis. When you have complete sacral agenesis, you obviously will have associated findings. This is cystic obstructive dysplasia of the kidneys, and you have a megaureter here. Very much often you see this is a dilated rectum, and you see complete absence of the anorectal canal here, and you see the line sign with absence of the perianal muscle complex, single umbilical artery, you can have in other cases persistent cloacal abnormalities. These are the postnatal pictures to show you how the spine abruptly ends here. You have the iliac bone seen here and the lower limbs. Now coming to the assessment of the lumbosacral curvature, because you can have some subtle abnormalities of the sacrum, and the clue to that will be assessment of the lumbosacral curvature. So reiteration of what we did in the first class, the lumbosacral curvature can be appreciated as from as early as 13 weeks gestation onwards, because what you're trying to see is not truly, you're not counting the ossification of the sacral spine. That is not important. What we are trying to see is, does is there an upward tilt of the sacrum? The upward tilt of the sacrum can be visualized from 13 weeks onwards to 18, 19, and 22 weeks. So when we are speaking about sacral agenesis or partial sacral agenesis, it is not whether S4, S5, S3 has ossified. It is whether the upward tilt of the sacrum is evident or not. The first clue is obtained from an abnormal lumbosacral curvature. So if you have, see, for example, you have a section like this, and if you have these elements missing here, if these elements are missing, that means it is the ossification of the sacral bodies are missing. But if the posterior ossification centers are not there, then you have to check whether they are divergent, and whether there is a spina bifida. So those two things we have to check whenever the posterior ossification centers are missing in a few sections. So now we'll go to all these case scenarios. So in all these cases, you know that there is an abnormal lumbosacral curvature. So obviously, you know that this spine has to be evaluated in a detailed fashion to know whether there is the presence of sacrum, and whenever we think about sacrum, the conus and the perianal muscle complex will come as a triad. And you also see vertebral abnormalities here. Now look at this. When I do a sagittal section of the spine, and I'm trying to focus on the vertebral body. So I'm looking at the anterior ossification center. So when I try to do the anterior ossification centers, look at this. I have inadequate ossification, missing ossification of the sacral spine, and you have one ossified sacral element here. So whenever you have a finding like that, in the same sagittal section, I will go and try to look at the cord. So the conus. So look at the conus and the last ossified vertebra, 9 millimeters. So obviously, you know it's a low-lying conus. And when you come to the medial convergence, so when you do the multiplanar imaging, so what you would see that these are the iliac bones. But when there is a partial sacral agenesis, see, the ossification is only there up to L4, L5 vertebra, and you see that this is the iliac crust, is it not? So L5 itself is only partially ossified. S1, S2 ossification are missing, and you see the medial convergence of the iliac bones in partial sacral agenesis. Leaving out the sacrum, we have finished about caudal regression, and now we'll come to isolated vertebral abnormalities. So the most commonest abnormality what we encounter when we do a coronal section is this laterally based wedge vertebra with alteration in the spinal curvature, which is a hemivertebra. Now, how do we identify this, and what are the clues when we do a routine examination of the fetal spine? So when we consider hemivertebra, you can have two types. One is a lateral hemivertebra, when you have one half of the vertebra missing, and this lateral hemivertebra is always identified in the coronal section. The other is a dorsal hemivertebra, where you do not have the ossification in the body, and here that will be always visible in the sagittal section. The commonest thing is what we call as a lateral hemivertebra, what we can identify in the coronal section. So when we come to vertebral abnormalities, so you can have missing unossified vertebral bodies, and whenever you have the axial sections, you can also look for this divergence here. And look at that. You can have a missing half of the vertebral body or clefts running across the vertebra. These are all vertebral body abnormalities what you can identify. When you do a sagittal section and you feel that there is something missing out here, there is some portion seen and something not seen, immediately you go to the coronal section, then you identify that there is a lateral wedge vertebra. The axial section will tell you that one half of the vertebra is missing here. You can correlate this with a 3D ultrasound where that missing, when you keep the reference dot in the missing area, you will neatly get this wedge vertebra here, and this is the hemivertebra, and you see that the reference dot is in the area where it is not present. So this is how you can correlate with just a sagittal acquisition, and wherever you find you have a problem, you can put the reference dot and correlate with the coronal section. Now coming to vertebral body abnormalities, you will have an array of abnormalities, and I do not know whether we will be able to identify all these with particular specification in the prenatal ultrasound. But what we need to know is very few things of importance when we come to identifying and counseling these patients. So, what are those important aspects we need to look at? So, when we see a hemivertebra, the fully segmented one, that what I just now showed you, that has a tendency of developing scoliosis. So this is what matters. Now you have the other ones which where you see the spine being straight. So as long as there is no scoliosis, the concerns for these vertebral abnormalities are very, very minimal. So these are defects of formation, a hemivertebra and a wedge vertebra. Whereas in defects of segmentation, when the vertebral bodies fail to disintegrate and when they are fused to each other, then we call them as a block vertebra. And if the what portion of the vertebra all fused together on one side only, then you have what is called as a bar formation. You can have both together, both abnormalities of segmentation and formation, which is a unilateral bar and a hemivertebra. But all these things make real is does it make a difference in prenatal ultrasound? I do not believe it is possible that we identify all these types. It's not possible. If you identify a hemivertebra, it is, I think that itself is something what you have done. But whenever you identify a hemivertebra, what are the steps you need to follow? That's what I'm going to reiterate in the next few slides. First of all, identification of a hemivertebra. So look at this. In the SAG section, it is little difficult. You might not know whether there is a hemivertebra or not. That is why commonly it is missed. But when you do the coronal section, very easily this will catch your eyes. Once you identify this triangular structure here, once you know that there is a wedge vertebra here, quickly you can do the just a volume acquisition, place your reference dot, and easily you can identify that there is a wedge vertebra here and at what level it is also through multiplanar imaging. So the first step is the coronal. Once you have confirmed your finding in the coronal, do the multiplanar and confirm it. So once in multiplanar imaging, we also have an additional advantage of not only knowing the level of where the abnormality is, you can also see whether the lateral elements, the posterior elements of the spine are present. So look at this. At this vertebral level, which is at T12 level, I know that this is the vertebral body and you see both the pedicles nicely here. This is the vertebral body and you see both the pedicles here. Whereas at this particular level, you see there is one missing pedicle here and you see the two pedicles here. So this is how you can correlate with the multiplanar imaging, the visualization of not only the vertebral body, but the vertebral body along with the posterior elements of the spine. And once again, the dictum is whenever you see a hemivertebra, identify the cord, look whether there is a hemicord or a tethered cord, identify conus and PAMC, because counseling is whether a hemivertebra is isolated or is it associated with other abnormalities. So why PAMC? Because when I say ANS, that means what comes into your mind will be a Vater or a Vactral association. So we'll see that. In the first trimester, you might have a subtle vertebral abnormality like this. What you see in the first trimester is The disc space is missing here. The intervertebral disc space is fine. You have vertebral bodies nicely. The disc space is missing here. If the disc space is missing here, that means you will have an abnormality of form of a fusion or a formation or a fusion abnormality. Then just check what happens when you see you do the coronal here and you see the sagittal, you see the block vertebra here, two vertebrae fused with each other, and that is how sometimes a clue can be evident as early as in the first trimester. Now, whatever might be the whether it's a block vertebra or a hemivertebra, or you can identify along with the rib anomalies an isolated hemivertebra in the lumbosacral region, there is a checklist to follow. The primary checklist is, first of all, as I already told you, cord conus PAMC. The second thing is look for associated anomalies, the most commonest being the components of the Bacterial association. So look, this is a hemivertebra, and you see that there is a unilateral renal agenesis. The vice versa. Suppose you have seen a unilateral renal agenesis. This is a lying down adrenal gland. There is a unilateral renal agenesis. This is the spine for you, and you see there is an LSVC here, LSVC in the heart. So bacterial can be very, very subtle. So you have a renal abnormality, you have a cardiac abnormality, and I just checked whether the anus, this is the anorectal canal, and I've shown the anorectal canal, so I know that there is the PAMC is intact, and I take a closer look at the vertebral bodies to know if there is a vertebral association or not. So when you do a closer look, when you take a closer look at the vertebral body, you see that there is a bigger vertebra here, and you see when you do the look at the size of the vertebrae here, look at this here, and when you do the multiplanar imaging, you will identify that there is a block S2 vertebra here, and this completes the triad of a bacterial association. All these things may be very, very insignificant, but to identify that it is a bacterial association, it is an effort to go and check whether all these abnormalities are present or not. There can be severe associations of a bacterial, like see, this is a radial aplasia, this is absence of perianal muscle complex, and you have thoracic vertebral up. You see the ribs here, the ribs are all crowded here, and you have thoracic vertebral abnormalities, and this is the other end of the bacterial association. Now we are finished with the hemivertebra, vertebral abnormalities per se, and whenever we think of vertebral abnormalities at the thoracic level, now this comes with another package, that is rib anomalies. So whenever you look at the thoracic spine and you have a subtle abnormality at the thoracic level, immediately we have to do a sweep to identify whether there is a rib abnormalities both in the coronal and in the sagittal section. So now I am not very sure of this thoracic vertebra. I'm not very sure. I feel there are missing elements here. Just look at the magnitude of the problem. See, look at the rib cage. So see how abnormal the ribs look like, and you know that this might be a spectrum of what is called as a spondylocostal dysplasia. But the clue was very, very subtle. This was the clue where the problem was seen as a missing vertebral segment here. So that is why evaluating the vertebral body and the intervertebral, look at the intervertebral disc space here. It's absolutely crowded, crumpled. Look at here, the lumbosacral region, it's looking fine. But here, the vertebrae are all looking bad. So this gives you a clue to identify further and go more. So as I told you, this is again another case. You see that the intervertebral disc space is not very good here, and you see something missing out right here. And when the clue first will be in the thoracic region, and then that can be associated with the missing ribs like that. Now, when you have vertebral abnormalities throughout the spine, and along with the very crowded ribs, then what we might be dealing with what is called as a Charcot-Levin spectrum. And what is the importance of identifying these syndromes is because the spondylocostal dysostosis or the Charcot-Levins can be autosomal recessive in inheritance, and then the chances of recurrence in the subsequent pregnancy will be as high as 25%. So now look at this. Now, this is the spine here, and obviously, the first attempt, the first clue is you see the missing. This actually, they are not missing, they are actually seen in the coronal view. In the sagittal, it will look as though there are missing vertebra, and the disc space will not be uniformly maintained. So, when you have an abnormality like this, of course, we can do a 2D sweep of the ribs, but the entire picture will come when you do the 3D. And as I told you, it's very simple. And you can see how the ribs are malformed here. This is how the normal ribs would look like, uniformly placed. And you see the curvature of the fetal spine and the ribs are abnormal here. And if you identify the subtle problem in the first pregnancy, look how the spine looks at 12 weeks in the subsequent pregnancy. At 12 weeks, you see that this, I do understand that the ossification centers of the spine will be very, very minimal. But look at the how the spine, the whatever ossification you see, in a few areas it is missing, in a few areas the disc space is not clearly seen. So you have a very disorganized spine here, and look at the ribs, how crowded they are at 12 weeks. And once when we understood, yes, there may be a recurrence of this condition, but 12 weeks was too early, because though we had all evidence, we thought let us wait for more ossification of the spine. So just look at 14 weeks of gestation. When the spinal ossification is little more better, you see how abnormal the ribs look like, and you see the pebble beach appearance, what you see in the mid trimester. See the vertebral bodies and the pedicles looking like as though someone scattered pebbles on a beach. So this is a very characteristic feature of a spondylocostal dysplasia. And this, by evaluating the spine and the vertebral bodies on 2D and then correlating with your findings on 3D, you can identify this spectrum as early as 16 weeks of gestation. Now coming to vertebral abnormalities. When I do the coronal section, now I'll show you two clippings. Now this is the coronal section and this is the sag section. I'll ask you to focus on this area. Now just view the clipping and you just let me know whether there is an vertebral abnormality or not. So when you see here, there is something which is catching your eye, because this vertebral body is fine, this vertebral body is fine, and there is something what worries me here is I do not know if there is something missing here, and if there is something missing, as I already told you, that if there is something abnormal, then I have to go and see coronal, and I have to check whether there is a hemivertebra or not. But again, my coronal section is not very, very satisfactory. But I really want to know what problem I'm seeing here. A simple volume acquisition. Place the reference dot exactly at this level. And when you do that, the answer is in your hands. See, what you see is just a coronal cleft of the vertebra. See, when you have a coronal cleft, there is no missing vertebra actually. This has a very, very benign outcome if it is isolated. It's only a normal maturation process of the spine. Hence, to identify or to differentiate a cleft vertebra, see, this is the cleft vertebra. This is the isolated butterfly vertebra, where you can see the cleft running through and through the axial bodies. This is this is a vertebral body and you can see the cleft running through. So these are very benign entities. So again, to differentiate, the steps are very easy. Proper 2D evaluation. If you have a query, a question mark, do your three-dimensional imaging, confirm, and then see what you are doing it. So these are simple coronal clefts of the spine, which are really, really not of concern. So now when you know it is that, then you can, on 2D only, you can image both the missing parts, but only that you need the mindset to understand that this is only a cleft. After that, we were able to see both. Initially, when I showed the clip, because it was missing, we could not, we thought, okay, it could be a hemivertebra, and hence we had to do the entire process to see. However, you see that in the coronal section, it was not very clear. The wedge vertebra was not seen. So that's how we correlate and identify vertebral abnormalities. So now I'm coming to the last concluding slides. So the key to identify vertebral abnormalities is once again this two-dimensional examination. Do not be carried away by fancy images of the spine and ribs, and we all and do not be disheartened that rib anomalies can be missed out. A simple sweep, a simple coronal sweep, a simple sagittal sweep of the spine will definitively give you a clue to the underlying malformation, and you will be able to identify the exact spectrum with multiplanar imaging, and you can show it in different rendering modes. But you have to suspect, and that suspicion will come only from a 2D evaluation. So the 5 important A's in the sonographic diagnosis of a closed spinal dystrophism would be: first, look for alteration in the spinal curvature. Remember the lumbosacral curvature of the spine. Whenever you have an abnormality in the lumbosacral curvature, look for abnormal posturing of the lower limbs. An abrupt ending of the fetal spine again is a clue for for a spectrum of a caudal regression, and always alignment of the ribs and the thoracic hemivertebra. If the abnormality is confined to the thoracic level, the alignment of the ribs has to be made in check on 2D and on 3D evaluation. If you have atypical or abnormal ossification of fetal spine, then you have to look into whether you are dealing with either a completely unossified vertebra or whether you have a wedge vertebra. To conclude, evaluation of the vertebral bodies and sacral tapering of the spine is the initial clue. Evaluation of the conus should be included. Evaluation of the ribs is an integral part in evaluation of thoracic vertebral anomalies. Meticulous search for associated anomalies is needed once a hemivertebra is detected. Usage of 3D ultrasound in evaluation of spine and ribs gives more diagnostic information than routine 2D ultrasound, but it is not essential for detection of CST. Thank you so much for your patient listening.
Amazing. Amazing in the word.
Thank you, Sushila.
Yes. Excellent. Your images are really magical spell. Somebody has already said. Maybe we can take some questions. There are more complex questions, I guess. But anyway. Please tell if it becomes difficult to evaluate conus as the gestational age increases in the second trimester.
I do agree with you, because what happens is you cannot insonate the ultrasound beam between the posterior ossification centers. It is a little difficult. But again, the point of why do we want it at that point of time, unless we have any very strong clues to evaluate the conus, because what I was showing you is in the routine mid trimester. When we go to the third trimester, conus evaluation is not a part what we do in the third trimester. Unless we have another abnormality in the spine, then we have to. And I agree it is a little difficult because the beam may not pass through. There will be a lot of shadowing from the lateral elements of the spine. It's a little difficult.
How to do vertebral body counting? From the ribs or from the last ossified sacral vertebra?
That we discussed in the last session itself. So to start from the ribs, it is T12, L1, L2, L3, or from the iliac crest, which is L5, S1, or from the last ossified vertebra. Anything is okay.
Yep. Ma'am, what's the difference between sacral agenesis, caudal regression, and sirenomelia?
All are the same spectrum.
Okay. Which method do you prefer for location of conus? Same thing. Routine target or FL-8 or 3D?
I do all. If I have a conus abnormality, I do everything. Because see, what are we trying to do? You're trying to identify more and more clues to give you more diagnostic confidence, is it not? I simply can't say low-lying conus by looking at one section. So I would obviously do my 2D SAG section. I would do the conus distance, and I would definitively do multiplanar imaging and confirm the level of the conus. I would do the entire spectrum. And more than it's a level, I also multiple times I reiterated the cord lifting away and touching the skin, and the divergence of the spinal pedicle. All these things will come to your help. It's just not the level.
Yeah, that is a very sweet image, very, very cute. The way you showed in the axial section how the cord is, actually elevated. It's very
Thank
cute.
you. Actually, that's a very useful clue. Very useful clue. But you need not break your heads on the stat section. One level low, you will be worried. What's happening? Is it a low lying bonus? But that really doesn't matter. If you show the cord is lifted, yes, it is that cord. Then it just gives you more confidence to counsel the lady.
But in the mid trimester, we just document the conus. We do not measure the conus distance
No,
unless.
no, no. Yes. We don't do that.
Yeah, for practice purpose, of course, because when there is an abnormality, you have to have
Yes,
your
yes.
act together. For practice purpose, you can do, but routinely conus distance, we do not
No,
document. as well.
routinely, if on a routine scan, we just look at the conus and stop with it. Only if you have a spinal abnormality, you do the entire exercise.
Right. Ma'am, how early we can identify sacral upturn? Or in other words, how early can we diagnose caudal regression?
You must wait for part 3, first trimester anomalies.
So that's being, taken care already. Very exciting. Is it possible to get recordings? We haven't taken the permission of these speakers, but in future, perhaps, yes. Ma'am, any red flags while we screen spine apart from loss of curvature?
Or basically what? Because the 4 steps, the red flags are in the 4 steps for sag, axial, and coronal. When you do the steps one by one, each step will raise a red flag depending on what abnormality you're seeing. Okay, so I for the entire spine, it's only those steps which are important.
Sure. Is there any chance to get confused between vertebral body and bony spur in the coronal section?
Yes, in the coronal section, you might get confused because you do not know at what level you're seeing. But if it is a vertebral body, you will see a single row continuously. But if it is a bony spur, it will be seen only in 2 segments or in 1 segment. So that's how in a coronal section you can differentiate.
Sure. Ma'am, is it possible to have an isolated low conus distance with no spinal defect?
Again, that's what I said. You should not rely on one parameter, which is the conus distance. The conus distance is only an adjuvant. If I identify a low-lying conus, then I just measure it supplement it with the conus distance. But I would obviously see whether there is a tethered cord or not. I think that exercise should be complete
Okay.
to label it as a tethered cord syndrome.
Sure. There are a lot of compliments pouring on your lecture. Thank you for that. And how to differentiate hemivertebra and osseous spur of diastometamelia?
It's an excellent question. The osseous spur is exactly in the central canal, is it not? So what happens? The osseous spur will be one step above. When you do the axial section, in fact, when I did the axial section, you saw the vertebral body lower down and the bony spur on top. So the osseous spur is actually in between. It's actually inside the canal, whereas lower down is the vertebral body. On the coronal, when you go up and down, you can see in the midline the osseous spur, and on the sides you can see the pedicles, and lower down vertebral body. Now, once again, the osseous spur cannot be continuous as the vertebral body, is it not? It will be there only in 1 or 2 segments, whereas the vertebral body will be continuous. A single row will be continuous.
Sure. So your images are mesmerizing, somebody said.
Thank you.
Can you give any tips for the high BMI spine imaging in high BMI women?
Again, for a high BMI, if your machine has an abdomen setting, you go for it. Leave off that OBGYN setting. Take off that harmonics. Take off, because what you want in a high BMI is at least what I struggle to do is if I can see the vertebral body and the intervertebral disc space, because only that counts. So we do not, even if we see like how we do in the heart, if it's a very high BMI, at least if you can see 2 inflows and the 3 vessel tracheal view with color, at least there is no major abnormality. So that's what is our try. Again, the more the frequency we use, it becomes very, very difficult. So your routine convex probe, get the frequency down, take off harmonics and look at the spine. But the next, if ever you have an electronic matrix probe, it does wonders in high BMI. It has nice penetration. Your volume probe, that also will help you for high BMI. All these things you can use, can do it.
So, do you ever use linear probe?
Yes, I often use the linear probe if the is okay. That means if the penetration is okay with me, because that gives the best resolution. I go for a C2-9 or a linear probe, both not on routine basis. Whenever I feel I need to have the spine at a little better, when I need to look it at better. For routine scans, we all whenever the dictum is use the highest frequency probe possible, which will give you enough penetration.
Sure. Is it necessary to examine conus if all planes of spine is normal in mid-range machine?
Actually, to look at the conus, there is nothing like a low, mid, and high range, because if the machine can resolve and show you the lumbosacral curvature, if your beam exactly passes through the midsection, it will show you the conus, because conus is not something which needs to be which you need can be seen only with a very high range. You only need a higher frequency. That's all. Second, including the conus is only a part of a protocol if you would want to do. As I earlier told you, the guideline has told you that if you evaluate the conus, it gives you more confidence on the integrity of the spine, and the guideline also has given you that. So you want to include or not is totally your choice. But if you find a spinal abnormality, you cannot forget conus. That's what I would want to reiterate. Any hemivertebra, anything, any point, because that really, really matters when you counsel the lady, or it matters to the postnatal counseling part. So that's very, very important.
Sure. So that is taking you for the prognosis. Prognosis of isolated lumbar lateral hemivertebra with mild scoliosis.
Again, for the prognosis part of hemivertebra, if you have ruled out all other associations, you have checked CORD, CONUS, PAMC, there's 3 points, and it is an isolated hemivertebra. The prognosis will only depend on whether the baby will develop scoliosis or not, which cannot be predicted at this point of time. As the baby grows, it can have scoliosis. Now, if you have a very obvious scoliosis at the point of when doing the scan itself, you make a mention that there is an obvious scoliosis. But if not, then the prognosis will depend on whether the scoliosis is going to is progress or not. It's the only hinge what we have to do. And very well, the pediatric neurosurgeon will do the next part of it. So that it. So generally, isolated hemivertebras have a very good prognosis. Only thing what we cannot say is whether later on it will progress, it will have scoliosis or not.
Yeah. Do the hemivertebra associated? Are they associated with spinal dysraphism? What is your
That is what I said. No, whenever you have a hemivertebra, it is that cord conus PAMC. When you check for the conus, when you look for the cord, you have to look for hemicords. Because if you have a hemichord, if you have a divergent, an occult spina bifida at 2 or 3 levels, then we are dealing not with a hemivertebra, with something else different. Hemivertebra along with, so that is why all those things are important. If there is a hemivertebra, the conus is absolutely okay, everything else is okay. You have ruled out a bacterial association, all other associations, all other things. Well and good. It's going to be obviously it will have a good prognosis. Keep this only into mind that progressive scoliosis we cannot say, we cannot predict. That's all. That's all.
Sure. If we see fluid behind the conus, can we rule out spinal dysraphism confidently?
Spinal dysraphism can be evaluated in the axial section by looking at the divergence of the posterior elements of the spine. That is more important. For checking whether the cord is tethered or not, the fluid helps you. For spinal dysraphism, it is the divergent posterior elements of the spine. Throughout my cases of tethered, neither or all cases of tethered cord syndrome, all cases of the subcutaneous swelling, I showed you the divergent spine, because the divergent posterior pedicles is a clue for spinal dysraphism.
Sure. By what gestation we can be sure that all vertebrae are ossified? As one article on fetal spine says that 25 weeks all vertebrae are ossified. So, what is your opinion? Somebody is
From
asking.
S1, from 16 weeks onwards, the sacral vertebra starts ossifying. And then you do not have a strict watermark line to say L3 will ossify, sorry, S3 will ossify at this time, S4 will ossify at this time. No, it's not possible at all. Sometimes you will never have ossification of S5 vertebra. Ossification, that's why once again I reiterated, ossification of sacral vertebra is not important when we do the prenatal ultrasound. What is important is the lumbosacral curvature. S4 21 weeks. That much is enough. At 21 weeks, if you see S4, we need not worry about S5 at all. It doesn't make any sense
Sure.
because the fetuses will have varying periods of ossification. That's what I'm trying to tell you.
Ma'am, what is neuroenteric cyst embryologically?
Again, as I said, it's what you call a portion of the ectoderm remains when the notochord integrates, that a disorder of notochord integration. So, what actually happens? You have remnants of the gut, and what happens is that is why whenever you have a cyst, it will be something like a enteric duplication cyst. Neuroenteric cyst will be something like derived from the gut, and it will be associated with a vertebral abnormality. So, a posterior mediastinal cyst, just look for vertebral abnormality, need not be at the same level, even higher or lower down. Most often, sometimes higher up. So, all posterior mediastinal cysts look at the check for vertebra. Then, if ever it's a vertebral abnormality with a posterior mediastinal cyst, then it's a neuroenteric cyst.
Sure. So, what is your advice for radiologists doing only 2D scans?
Oh my God! Please do not ask me that. Why I'm trying to tell you is as I told you, my last slide clearly told you that the suspicion is on two-dimensional ultrasound. I said do not be carried away by fancy 3D images. It doesn't matter at all. Whether you do 2D, 3D, and everything, if you don't suspect on the initial 2D only, how will you do the extended spectrum? You're not going to suspect. So whoever is imaging, just be sure on the 4 steps for sagittal axial coronal. If you have a suspicion, then you refer.
Sure.
I think that's a way out.
Yeah. Anytime 2D is the first step.
Yes, it's the first step. And there is nothing, so I showed you so many case scenarios. There was not even one case which did not have a finding on 2D. All of them had a finding on 2D. So 2D is more important.
Sure. Ma'am, can you repeat all the 4 steps again?
Oh yes, these 4 steps are going to. Okay. I will share. I will do it at the end, Sushila. After the doubts, if I have to once again share my presentation, I can show something more.
Can there be a splaying of posterior spinal element on coronal view without any obvious bony spur?
Yes, if there is, do the axial section and check for a hemichord because you're dealing with a diastomatum. You might be dealing with a diastomatomylia with a fibrous partition. So if you are very sure on the coronal sections, you have divergence of the pedicles. Quickly go axial and see whether the cords are split or not.
Sure. Fine. When there is scoliosis, how do we check for CADA? Any tips?
Scoliosis check for cauda means cauda equina. What is it they want?
CADA equina, perhaps they in their opinion.
The same thing. What is for holds good for conus. The sag axial views. If there is scoliosis, also doesn't matter. No, at the lumbosacral spine only. Why you are going to hit this through the posterior ossification centers? So the evaluation of the conus is the same. Whether there is diastomatomylia, whether there is scoliosis, whatever spinal abnormality, the steps for conus are the same.
Sure. Points to check on follow-up of confirmed closed spinal dysraphism. Are limb movements good predictor? If so, what is the minimum time we need to observe for?
Again, see the posture. Actually, limb movements they actually get fixed with one posture. If you have for the sacral agenesis, the limb movements do not actually predict what is it. The first clue will be the spine. The second only you will have to look at the limb. If you have spastic lower limbs, then you have to go. You can just go and check for the spine. It's not that you have to wait for the limb movements. Not at all. No, it's not like that. Because the muscle wasting everything will be already done already got over. So you'll have spastic lower limbs.
Sure. So this question I really like. Ma'am, how to differentiate kyphosis and scoliosis on scan?
Oh,
Most of
great.
the time, most
Yes.
of the times
Go
we
ahead, go ahead.
report it as scoliosis, and the neurosurgeon calls back that it is kyphosis.
I do not know. I do not know. I follow this. Maybe if someone knows, have a better idea, you please tell me. On the sagittal section, if I see an abnormal curvature, I call it as kyphosis. On the coronal section, if I see an abnormal curvature, I call it as scoliosis. That's all I know. And that's all I do. Because a kyphotic deformity is more seen in the SAD section, in the SAD section of the spine. A scoliotic deformity is a lateral when you do the coronal section. If you see this alignment abnormality, then it is scoliosis. This is the clue I have. If anyone has a better idea, please let me know.
I think we also follow the same, but also to
Okay.
save our skins, we can also consider it as kyphoscoliosis.
Okay. If you have both, if you can see it in both
Yes.
sections. Okay.
Uh, can you elaborate on butterfly vertebra, block vertebra, wedge vertebra, and platypus spondyli?
Okay. See, in platyspondyli, what happens? The vertebral body thickness is less. The intervertebral disc space is more. That is platyspondyli. Nothing to do with abnormalities of the vertebral formation or segmentation. That's platyspondyli. In a wedge vertebra, what happens? Only one portion of the vertebra, half of the vertebra is missing. Only one portion of the vertebra is missing. That is wedge vertebra. A block vertebra is two vertebrae are fused together. The intervertebral disc space is absent and both the vertebrae are fused. That is block vertebra. What was one more, Sushila, you asked me? Block, I said. Wedge, I said.
Coronal
Platyspondyli, I
cleft.
said. Coronal cleft. In a coronal cleft is what is, you have a little, the remnant of the notochord between two portions of the ossified vertebra. Nothing is missing here. There is only a cleft running across the vertebra. Both the portions of the vertebra is there. That's a coronal cleft that has a very benign nature.
Sure. How to rule out a closed lower sacral dysraphism?
Very, very simple. Your axial sweeps. Something must give you a clue. If you feel lower down lumbosacral region, you are worried. You remember, maybe I can reiterate, I can show you the axial sweep. You look for convergence of the pedicles, of the posterior elements of the spine at each level. So even at the sacral level, there will be convergence only. If they are divergent, then you do the protocol.
Sure. Can you please tell the diagnostic features of partial sacral agenesis on ultrasound?
Yes, once again, for partial sacral agencies, first clue will be abnormal lumbosacral curvature. That is what is important. Again, you have to see minimum S3 ossified vertebra. See, I said S4, S5, we are not worried. But S1, S2, S3, you must have it ossified. If you do not have ossification at S1, S2, S3, or you have medial convergence of the iliac bones, then you suspect a partial sacral agencies. But the first clue will be abnormal lumbosacral curvature. That's why that curvature is so important. The upward sacral tilt of the sacrum.
Okay. Ma'am, if patient is continuing with a fetal closed NTD, how frequently should we follow her?
Generally, a fetal closed spinal dysraphism, once diagnosed and once you have on counseling is done postnatally with the pediatric, there is nothing called a progression in a closed spinal dysraphism. Whatever, except those hemivertebrae which may have scoliosis in utero only, progressing scoliosis in utero. That is the only thing. That too, there's nothing more to do. So basically, for closed spinal disruption, there is nothing like close follow-up, nothing. When you're diagnosed, your diagnosis is done. Then after delivery, she needs to see the concerned pediatric neurosurgeon. That's all.
We have a different challenging situation in the clinical practice because there are no cerebral signs. There is a possibility that, unfortunately, the closed, spinal defect may be missed in the second mid-trimester scan as well. So,
Yes.
and then if it is picked up in the third trimester, it becomes all the more challenging to talk to the couples. So, can you share your experience if you have similar? I'm sure you have.
Of course, we have identified diastometamylias in the third trimester. But again, for me, that was not more challenging, Sushila. In my setup, I now also see open neural tube defects in the mid and third trimester. That is what really is a great challenge, what I believe we face. Because the closed spinal disruptions, anyway, the baby is going to do well. In the hands of advanced surgery, okay, anyway, they're going to do well. Because I only thing is the parents might ask why it was not told in utero. But the implications behind the child is obviously going to be very, very less when compared to open neural tube defect. I believe this open neural tube defect only is getting missed. And we have even now we have late detection of open neural tube defects. Second, for this, again, it depends on the severity of what you're seeing, the closed ones, whether what if you're thinking about diastometamylia or large closed neural tube defects, which can be missed out. All those things will definitely have a tougher time in the postnatal period. But the only thing what concerns me in the third trimester is how good are we in evaluating the spine. This we already discussed earlier. Because all portions of the spine, how comfortably we can do all the three sections in the third trimester. All these things are important. So for me, in the third trimester, I mandatorily see that at least I can see the skin line. Because I do understand the intracranial signs will give you a clue, but um, if you have a subcutaneous swelling, it will be evident. So at least if you can see the skin line and you can see that there are no gross vertebral abnormalities. And the other thing, what is really important in the third trimester is the spondylocostal dysostosis. That will be very evident when you do, because that time the spine becomes too much. When you keep your probe on the spine only, you will understand this something gone wrong. So those things are really very, very tough and very, in fact, very difficult to counsel, because you know the prognosis will be very poor in those conditions. That should not have been missed in the mid trimester. That those parts are more uh, little
I'm
difficult
sorry.
to handle.
I completely agree. In fact, when you gave me this schedule of second session on closed spinal dysraphism, I was about to ask, like, Array, why are we missing on open neural tube defect? Because still that is the commonest pathology.
Correct,
But
correct,
I
correct.
thought, you have something in reserve for us for the first trimester. That's why.
Okay. So, so because today it is like today we are 80% of neural tube, open neural tube defects must be picked up in first trimester. So for the first trimester, it is reserved.
I know. That's why I thought, you have kept it as in reserve for us in the first trimester. That's why I did not interfere with the flow that, you gave. There are, the same questions like the prognosis of isolated conus picked up in
Yeah,
the
just now I explained.
That's all. I think
Then I will share my slides, Sushila, and I'll just show
that's
them that the first three
4
slides.
points. 4 points.
Yeah. The 4 points.
Yeah.
No, I have to just go back. Are you seeing the slides? The first
Yes.
slide? Yeah. So this is a so is the sagittal section evident?
Yes, please.
Okay, great. So in the SAT section, what are the 4 hints what we need to do to look at the spine? The first thing, as we often do, skin. Then the spinal curvature. When you do the spine, you look at the 3 lines, is it not? One is the skin line, posterior ossification centers, anterior ossification centers. So vertebral body, intervertebral disc space. Then assessment of conus. So 4 hints. In the axial, skin and soft tissue overlying the spine, convergence of the posterior ossification centers. That is a clue for spinal dysraphism in all levels. Evaluation of the vertebral body per se, evaluation of the cord for hemicords or tethered cord, and the position of the cord in relation to the vertebral body. That is axial section. 4 steps. Skin, convergence of the posterior ossification centers, evaluation of the vertebral body, assessment of spinal cord and its position in relation to the vertebral body. In the coronal, the first section will be the single row of echogenic foci. So this is the section through the vertebral body. This is section through the pedicles, where you see two parallel rows of echogenic foci. If you have a bony spur, it will be evident here. Okay, here at this level, you can see the bony spur. Then evaluation of the ribs when you do the coronal sweep, and then assessment of the sacral tip in relation to the iliac bones on a coronal sweep. So the 4 points. Okay?
Yep. Great. It must be very exhaustive for you, though exciting for us. Many, many thanks, Dr. Lakshmi, for all your time, energy, and then, the images that you shared with us. And
Thank
then we
you so
look
much.
forward, for the next session as well. Thank you very
Thank you.
much.
Thank you, everybody. Thank you. Bye.
Bye. Thank you, everyone.